I will be talking about trauma-informed research, which is a framework we've sort of developed along the process of my study evaluating the Centering Anti-Racist Education or Care Pregnancy Tool. And I'll be talking a little bit about some foundational frameworks and definitions that have been really important to us. And then I'll talk about how our research can be sort of a representation of how these frameworks can be applied to research. The first thing I really want to mention is the framework is trauma-informed care. This is a framework for providing all care, not care for trauma, but really all medical care that recognizes the prevalence of trauma in the lives of all people and creates policies and processes with this in mind, and then seeks to actively avoid re-traumatization. This is the main framework we've sort of developed to try to apply to our research, particularly in less protected populations and community-based research. So thinking about trauma briefly, thinking about it as an event or exposure, then an experience of that event or exposure, because we know that people who experience the same traumatic event can have different experiences of that event. And then the effects, or particularly the health effects or the effects on our research relationship of that traumatic experience. So we know there is a whole variety of traumatic exposures that people experience. We know sexual trauma in particular is incredibly prevalent. About 1 in 4 women report sexual abuse as a child. 1 in 13 men report sexual abuse as a child. 1 in 6 adult women report sexual assault as an adult. It's incredibly common. But we also know there are other types of trauma that people experience, including community level trauma. So this is sexism and patriarchy, sort of racism, homophobia, poverty, police brutality, all of these environmental exposures, as Dr. Carmichael went over beautifully, really impact people's ongoing experiences of trauma. And then we know there are very specific health effects of trauma, but we also know that there are research effects of traumatic experiences with research in the past. And I know I don't need to go through the whole history of traumatic experiences, particularly for less protected populations in research, but we haven't done a great job in medicine and research of earning communities' trust. And some of the effects of this are a lack of trust in us now, lack of collaboration. We have a lot of community organizations that are working to solve similar problems and asking similar questions, but not collaborating with academics and research institutions. And then importantly, we have fewer people representing these less protected groups, particularly when we think of Black people, women, and underrepresented minorities in medicine and in research, which is very important in terms of who's asking these questions and who has lived experience to really think about how to best ask these questions. Briefly, I want to mention the ACEs study, which just shows that the effects of ongoing exposure to trauma are very real. The initial ACEs study looked mostly at abuse and neglect as a child, and it showed a huge impact on many factors, including an impact on mortality. And then subsequently, there have been many studies looking at expanded ACEs or adverse childhood events that really include community level adversity. The Philadelphia Expanded ACE questionnaire is probably the most well known, but looking at whether someone has witnessed violence, felt discrimination, had an adverse neighborhood experience, including witnessing police brutality. And those can be also very correlated to health and health interactions. So I think these are all just an important framework to keep in mind as we are increasingly more interested and realizing we need to be more interested in asking research questions about how we can better serve and better create systems for populations of people that have been traumatized in a very chronic way. And then trauma-informed care and our trauma-informed research is really designed with this as the core value, which is to avoid re-traumatization. We know that re-traumatizing behavior is anything that triggers or reminds someone of a traumatic experience. And this is so big in thinking about reminding someone of racism, reminding someone of feeling less powerful, of reminding someone of feeling dehumanized or that they're being coerced into something. And these are things we've done all the time in medicine and in research historically, and important. So this is why this became our most core framework value in doing community-based and community co-created research. So a trauma-informed approach has these 6 principles in terms of providing and creating systems that are trauma-informed. And I wanted to highlight just a few that we've really emphasized in our research, which is transparency and trustworthiness, having this be such a critical part of creating a research plan and a research team. Peer support and collaboration, having the vulnerable populations or the less protected. I actually don't love the word vulnerable. I think it's really less protected because it's not a weakened group of people. It's people that have been less systemically protected. Making sure community members from those less protected groups are part of every aspect of a study that involves and is about them. And that we're really empowering people to be involved and to shift in very big ways, the ways we're doing research, the questions that we're asking. The next framework that I'm going to talk about is critical race theory, which has had a huge national conversation recently, but to demystify it perhaps for many people, it is an academic and legal framework whose central tenet is that racism, not race or not individual racism, but racism in a structural way is contributing to disparities by race as the result of complex and changing social and institutional dynamics. It talks specifically about re-examining what we have deemed objective approaches in the past, because we know that into all of our structures and institutions, racism, sexism, all of these things have been built into them, and it's part of our job and in our best interest, and so important to doing meaningful research that can really be impactful, to examine these and figure out how could we make these better, and is there any way we could remove some of that bias? And then also this concept of centering the marginalized groups is a critical thing in research, of thinking that if we focus on the most marginalized groups, thinking about the people who have the least amount of protections. In the case, as you saw from Dr. Carmichael, one of the big groups that we think about is Black women when we think about maternal mortality. If we focus on the needs, concerns, systems that aren't working for Black women, we can build out from that into systems that benefit everyone. And then also that work must be action-oriented, that we can't sort of have a conversation in an ivory tower by ourselves, that we really need to make sure even throughout the research process, things are impacting the community that we're trying to serve. And then intersectionality is this framework developed by Kimberly Crenshaw that really talks about how none of us are single issue people, to paraphrase Audre Lorde, but we all have overlapping and interdependent systems of privilege or discrimination that work to our advantage or disadvantage. And particularly for Black women who are at the intersection of racism and sexism, it's not beneficial to look at one of those biases without looking at the others or other types of biases. And then finally, the last framework that we've used in our research is an anti-racist praxis for looking at public health research. This is the reference I would use for most people, but really thinking about Faith Fletcher, Wendy Zhang, and Alicia Best have developed a framework of trying to apply critical race theory into more of a research focus with some more explicit instructions, which has been really helpful. And I hope to contribute to this conversation, and that this is a conversation we keep having about how to do better research. So with that, now I'll talk about how we sort of applied those frameworks to the Centering Anti-Racist Education Pregnancy Tool, Co-Creation and Evaluation. So I created this tool with my friend and colleague, Erica Chidi, who is the CEO and reproductive health educator at Loom, which is a nonprofit organization that provides sexual health education in a reproductive justice framework. She identified this need. We started working on this in summer of 2019 and identified this explicit need of an actionable and compassionate tool centering Black pregnant women's needs and mobilizing care providers to directly acknowledge racism. And summer of 2019, there has been a huge change in how we're discussing racism since that period of time, but this is where we started. And it was really in response to some of the data that Dr. Carmichael and others have showing that there's this huge disparity in maternal mortality for Black women. But really, as an academic and clinical space, we hadn't provided any tools. We had just said to Black women, like, wow, this data is very scary. Let's work on that. But for the people who are actively trying to become pregnant or pregnant, it was terrifying. And so Erica wanted to co-create a tool that basically reviewed all of the literature, applied a framework in reproductive justice and intersectionality, and created a tool that Black women could use to help advocate for themselves. And so when we sort of talked about this tool, we talked about whether we should use a methodology that was more familiar to me in terms of a research method versus creating the tool and then evaluating it later in sort of a more backward method. We wanted to look at explicitly addressing systemic racism, and then co-creating with community organizations. And we really emphasized that co-creation. Questions that came up for us here was thinking about whether or not we should do a typical research process where we really evaluate the tool and then release it once it's been sort of validated and evaluated, or if we release it right now and then evaluate it afterwards. And that's what we decided to do because of the frustration that many people felt about and continue to feel about how slow we are in academics sometimes in identifying a problem to having usable solutions for the community. So we reviewed the literature and then had a review by community stakeholders, specifically Melanse McAfee from the New York Times and Rose Ika James from Black Mamas Matter, and had amazing revisions from them. And then we published it in the New York Times. So it was published in October 2020, and we had amazing response to the tool. But one of the big feedbacks that we got was that it put a lot of pressure on Black women to introduce this discussion. But it was the first tool that people really could use. And there was a lot of excitement about it. There still is a lot of excitement about it. So then now that the tool is out there, we thought we should create more of a specific study. And so we created a study team with some of these questions in mind, thinking about a trauma-informed approach of how to best involve the community, how to equitably involve the community. And so we created an amazing study team with some huge advocates from the community of Black women who serve and work for the other Black organizations that support Black pregnant people. Sorry, better way to say that. Terms are really important. The big questions that came up for us and really has taken us almost 8 months to really figure out is figuring out appropriate compensation. This is huge when doing community-based research and is kind of unglamorous when we talk about research, but is so critical in making sure we are appropriately valuing and equitably valuing people's time. We had a lot of sort of funny, not so funny things about how to list people on grants. I kept getting asked for Erica Chidi's bio sketch. She doesn't have an NIH bio sketch. She's has been working for the past 20 years, but hasn't been creating academic publications. And that was very confusing. There really wasn't a structure in place to allow this to happen with grants. And then really creating some self-reflection for biases. These are some of the things that came up for us. And one of the biggest things was really, how do we minimize re-traumatizing this community? One of the big things that happened with this sort of awakening to structural racism is that all of a sudden people were sending hundreds of surveys and things to Black pregnant people, to other less protected populations who had been incredibly traumatized by the past year, not to mention previously. And we wanted to really avoid that. One of the big things that came up for us is, how do we define Black women? How do we really decide who to incorporate in this? And then how do we balance the burden of participating in research meetings with the importance of making sure voices are heard in this? So our creation of the collaborative research team, we thought would take a few months and really has taken almost a year. It has been such an important learning process about how to do this equitably, how to do this appropriately, how to have lots of self-reflection for our whole team and how we are approaching this collaboration. And then we realized in our collaborative research group that we didn't really have a great sense of how to introduce the tool, that we sort of had this tool and we were like, great, let's evaluate it. But we didn't actually have a way of saying, now we should talk about race. And that was one of the most important things that came out of those initial discussions, is we don't have a great way to introduce, hey, you are a Black pregnant person and you have this increased risk of maternal mortality. It was very awkward to do. So we are now doing interviews with community stakeholders. We intend to do interviews with intended users or Black pregnant people who have been pregnant in the past year. And then we also are doing a survey of Black pregnant people who have been pregnant, or Black people who have been pregnant in the past 5 years, interviews with intended recipients or care providers. And then ultimately would love to do the actual gold standard of tool evaluation, which would allow us to sort of validate it, which is an RCT of how the tool would be used in clinical practice and measuring outcomes. And then analyzing those things together to really create the final anti-racist pregnancy tool. These are our interviewers from our research study. This is sort of ongoing right now. And then I'll kind of end with this, that these are the big questions that came up for us, which is really this sense of urgency that our community co-collaborators were saying, like, this is a white academic problem. We have had this urgency forever. This is not a new issue. We don't want you to create tools that are band-aids or making you feel better about this issue. We want you to create meaningful change. And that is going to take longer, but don't rush this process just so you can write something on your CV. And so I've really tried to hold that, even though it is very hard against all the timelines of academic medicine, but I think it's so important. And then finally, how we report back to the community throughout. One of the best things that we had was one of our community experts said, like, you need to ask a question in your survey that is just for the community, that doesn't inform your research, but will really help give back to the community. And so that's been a huge takeaway for me. Thank you so much. I'm happy to answer any questions. And this is our website if you want to learn more about the research.
Great. Thank you, Dr. Cahill, for this timely, thought-provoking, and truly critical work. We do have time for one question, and it piggybacks on one of your slides, and that is, how did you find these community partners? Who you choose to work with is so important. Can you spend a little bit more time elaborating on making those connections?
Yes, thank you for that question. I think that is so important. We know there's such a fine line between tokenizing people and really co-collaborating. And what I want to really avoid promoting is finding someone who looks like the less protected population that you're trying to do research on and asking them to collaborate with you. I think really having someone who's also a community organization or another researcher who's already doing this work and lifting them up is really the best thing. Erica Chidi and I have collaborated for lots of other work. I am an advisor to her Loom company, and we've been sort of having conversations about reproductive and sexual health for several years. And so I think this was born out of those relationships, which is more to say, like, we should all be doing more to have real relationships with diverse communities in general, but then really thinking about how to approach people in a way that feels like you're lifting them up and not necessarily trying to tokenize people. And there's not a perfect answer, but I think the awareness of that is really important.